Hi, this is Brian Kim. I'm going to share with you this case of a patient with an atypical stromal dystrophy with cloudy cornea. You're going to see double chop, cross chop, mechanical fracturing, and how I disassemble this lens in the context of a cloudy cornea, and how I do cataract surgery in general. So I'm using a corneal marker to help me center and size my rexus. You can see this very strange looking corneal haze. It's mainly on the right side of the screen here, but the entire right half side of the screen, especially in the mid-periphery peripheral area. I'm making my paracentesis incision first on the right side and then the left side. This is the left eye, and I'm making sure the incision is flat to the iris plane so I can have a nice self-sealing corneal shelf. I'm injecting some intracameral lidocaine and then some dispersive viscoelastic to fill the anterior chamber and flatten the anterior capsule. So again, I'm asking my technician to give me some more fluid on the cornea, but you could tell it's still got this weird, around the mid-periphery, 360 degrees, got this weird looking corneal appearance. So I make my vertical groove from my triplanar corneal incision, place the blade into the deep part of the groove, tunnel through the cornea, use a cannula to turn the eye towards me, and then enter. And that's the triplanar corneal incision. This is going to be my puncture style capsulorexis. I like to turn the tip sideways when I go in now. It makes it a lot easier and it doesn't snag the incision. So I puncture. And pull it downward towards me subincisionally. And then I begin the rexus, grabbing the right side of the tear to create a flap, going around circumferentially, trying to use the corneal marks, which will help me to center and size my rexus. You can see here I'm taking my time, making sure I go around. By doing so, I have a nice controlled rexus. And then I finish off the rexus and burp a little bit of viscoelastic out of the eye. And this will begin the capsular fornix hydrodissection technique. I place the cannula out to the contralateral equator underneath the anterior capsulorexis edge, point the tip down, get a nice fluid wave, turn the tip back up, decompress on the left side, turn the tip to the right side, hook it downward, and it begins to spin quite nicely. I could tell that the epinucleus came off with the hydrodissection, so there's not going to be an adherent epinucleus to the bag here in this case. I lift the incision with the chopper, go in with irrigation off to minimize Descemet's trauma. I'm removing the surface epinuclear material. Place the chopper underneath the rexus edge out to the equator. Place the ficatip vertically subincisionally. Bring both instruments together, crushing the lens and dividing it completely in half. That's the double chop. Place the chopper out to the contralateral equator, pulling it centrally toward the ficatip, crushing it and bisecting the right heminucleus. That's the cross chop. I use a little bit of vacuum to lift that first quadrant up and then place the chopper around the lens, crushing it and sandwiching the lens piece and using high vacuum and ultrasonic energy to emulsify the lens pieces. Now I'm going after the second quadrant. I'm placing the chopper underneath the rexus edge out to the equator, pulling it centrally. I stop and go again because I'm not 100% sure I'm within the bag. To do the same maneuver, pulling it centrally, crushing it against the ficatip, and then I start to emulsify the fragments. I'm going to turn the second heminucleus in front of me, place the chopper out to the equator, pull it centrally towards the ficatip, crushing and dividing that second heminucleus in half. Do the same maneuver, dividing that third quadrant, grabbing the fragment of the third quadrant with high vacuum, pulling it up, crushing it with mechanical fracturing forces, and then emulsifying it with high vacuum and ultrasonic energy. I prolapse that second fragment up with the chopper, crushing it against the phaco-tip, and then emulsifying the lens piece. I'm placing the chopper around the fourth quadrant, hooking it, mobilizing it, and then pulling it and crushing the lens piece against the phaco-tip, and then emulsifying the lens pieces. Once I have it on the tip, if I want to use mechanical fracturing, I just go ahead and crush the lens piece with the chopper. So at this point, I'm going to remove the epinuclear material. You see there's a little bit stuck to the cornea. That just shows you I have a lot of viscoelastic still stuck to the cornea and protecting the cornea. I take the chopper out, push BSS in, take the phaco-tip out, and then go in with the INA handpiece. And this just helps me maintain some chamber stability. I adjust the sleeve, and then I start subincisionally grabbing the anterior cortex and peeling it off from anterior to posterior, sweeping side to loosen it, and it comes out pretty nicely. I'm just adjusting the sleeve some more there. So switch to the polish mode and start polishing underneath the rexus edge, removing any lens epithelial cells, and to look for any potential cortical material. Start to polish on the posterior capsule surface now. Again, you don't need any aggressive strokes. It is my opinion that you shouldn't be too aggressive with posterior capsule polishing because sometimes the posterior capsule is weak and the zonules are weak. And so you don't want to really grab it in that context. So just tease it very gently with the polymer tip. Use a cannula to pulse BSS into the subincisional capsular fornix. It looks pretty clean there. And then I'm injecting some cohesive viscoelastic to fill the bag and chamber. And then I switch on the other side with the sweep. And I'm going to sweep underneath the rexus edge. Again, making sure I polish and remove any lens epithelial cells that are there. Once I'm satisfied with the polishing, I inject the single piece acrylic intraocular lens into the capsular bag with the leading edge in the bag and the trailing edge out of the bag. As it's unfolding, I quickly place the INA handpiece in, activate irrigation, inflate the bag. With the bag inflated, I can confidently deposit the rest of the lens into the bag. I'm teasing the haptics off the optic, go underneath the optic, tilt it, and rotate it 90 degrees clockwise. I evacuate the bag completely, making sure there's no viscoelastic in the bag. And then I push the optic down. I'm going to turn the haptics in the horizontal configuration. So I switch to visco mode to remove all the viscoelastic from the anterior chamber, and then I'll hydrate my incision. So again, this is a patient with an atypical stromal dystrophy. The view is a little bit compromised because of the stippling all over the surface of the cornea. There are some people who will cover the eye with viscoelastic. I've never been in the habit of doing that, but I think that's a really nice maneuver. But in this context, you can see I'm able to use double chop, cross chop, mechanical fracturing techniques. And even when the view is not completely clear, because I know where my instruments are and I know the principles of making sure the instruments are within the bag, using crushing forces to bring the instruments towards the center, This is very safe. It doesn't damage the bag. It doesn't damage the zonules. It's very safe because it uses maneuvers and manipulation away from the zonules in the bag. And because I'm not using vacuum or ultrasonic energy when I'm doing these crushing maneuvers, it's very safe because normally if you have high vacuum and you get close to the bag or the zonules, you could inadvertently grab the bag and cause damage with a high vacuum. That's the one thing with vacuum, which is, again, advantageous when you do it correctly, but when you do it incorrectly can cause problems. And so it's really just a non-issue with this technique. So I hope this was helpful to you, and I thank you for your attention.